Up next, Raymond Gibbons and Dr. Jonathan Piccini, Assistant Professor of Electrophysiology at the Duke University Medical School in Durham, North Carolina, discuss quality of care, symptoms, and one-year outcomes for women and men with atrial fibrillation, primary results from the Orbit AF registry.
Welcome to ACCEL, Jonathan.
Thank you for inviting me.
What in the world is the Orbit AF registry?
The Orbit AF registry is the outcomes registry for better informed treatment of atrial fibrillation. And it was started in a setting of lots of ongoing science with atrial fibrillation and explosion in AFib studies, as well as an emergence of several new therapies for the treatment of AFib. It's a longitudinal registry that will collect follow-up outcome out to 3 years, and it's enrolled over 10,000 patients. Additionally, there's a patient-reported outcomes sub-study that's examining AFib-related quality of life in approximately 1,500 patients.
So how many total centers in the registry?
184 centers across the United States and the U.S. territories.
And when were these patients enrolled that we're going to be talking about today?
They were enrolled between the summer of 2010 and the early fall of 2011.
Tell the audience a little bit more about the quality of life measurement that was made in this study. Everybody's used to asking their patients questions about symptoms. How was that done systematically in this study?
So we were able to use the EFFECT questionnaire, which stands for the Atrial Fibrillation Treatment Effects on Quality of Life questionnaire. And it's a very well-validated questionnaire that has 21 items. And those items query patients on several aspects of atrial fibrillation, including how they experience daily symptoms, how those symptoms impact their day-to-day activities, their ability to exercise, their ability to do the things they want to do, as well as questions about how atrial fibrillation affects their outlook on life, their potential anxieties, and how they've responded to treatment and how they perceive their treatment.
So I know you showed me the actual questionnaire on the computer screen, and for example, one of the questions was about palpitations with a scaling of whether people felt it limited them or severely limited them.
That's right. It's an important point. It's a Likert scale, so patients can, select a range of how significant or severe their symptoms are.
Okay, so I think that'll give our listeners a sense of what this registry is about and the measurements. And you started out with what hypothesis?
We're looking at one-year outcomes, and we know that women who get a diagnosis of cardiovascular disease often have worse outcomes than men. And so we hypothesized that women relative to men would receive different treatment and have differential outcomes. And so that was the hypothesis we set out to evaluate with this study.
How did the women compare to the men at baseline?
So at baseline enrollment into the study, women were older. They had higher risk of stroke, including a higher prevalence of prior transischemic attack or stroke. They had a greater prevalence of hypertension, and they had higher CHADS-2 scores. On the other hand, they had less coronary artery disease than their male peers, and they also experienced less sleep apnea.
And how did their treatment compare?
It's very interesting. When we looked at rhythm control strategies between men and women, the proportion of men and women on rate versus rhythm control was very similar. 68% of the cohort was on rate control strategy. There were some differences between the two arms, but in general, women were just as likely to receive antiarrhythmic therapy. And there were minimal differences in cardioversion and catheter ablation, although numerically more men than women received those interventional therapies.
Okay, so the women looked sicker at baseline than the men, but were treated very similarly to the men. So how did the one-year outcomes look?
In addition to rhythm control strategies, we also looked at stroke prevention therapies. And again, the treatment patterns were fairly similar in patients who had a CHADS-2 score of greater than 1 and no contraindications to oral anticoagulation therapy. Approximately 60% of both the men and women were treated with an oral anticoagulant. And if we look at another performance measure, the time between INR measurements, women did a little bit better than men in the frequency of their INRs, but when we looked at the time in therapeutic range, men did better. Their time in therapeutic range, or TTR, was 68% compared to 65% in women. But what's very interesting is when we looked at the outcomes, the major hard cardiovascular endpoints of cardiovascular death and all-cause mortality, after we adjusted for important clinical differences, women did better than their male peers. They were less likely to have cardiovascular death, and they had better all-cause survival.
So you thought they were going to do worse, but they in fact did better, even though their baseline characteristics were worse.
That's right. Even though their stroke risk was higher, they had better survival than their male peers.
And how did they do in the realm of symptoms and the quality of life assessment?
This is perhaps one of the most important findings, I think, from this study and from the registry. When we looked at both at baseline, women across the board had more symptoms than men, despite having less severe types of atrial fibrillation. So women were more likely to have paroxysmal AF. They were less likely to have persistent or permanent atrial fibrillation. However, they had more palpitations, they had more exercise intolerance, they had more fatigue, lightheadedness, chest discomfort. When we looked at quality of life scores using the EFFECT questionnaire, we saw that women had worse overall quality of life, and they had worse quality of life in those 4 crucial subdomains of the EFFECT score, including symptoms, impact on daily activities, treatment concerns, and treatment satisfaction. And when we adjusted, we saw that women indeed had worse quality of life. And when we looked at those quality of life scores 1 year later, we still saw a persistent gap in both symptoms and quality of life.
So it sounds like the message for clinicians is that they probably should be paying more attention to symptoms in women to make certain that the treatment actually helps to improve their quality of life, because, at least in this registry, it didn't.
That's right. I think you've summarized the clinical implications of our findings very well, that when we see women with atrial fibrillation, we really need to keep in mind that they are at higher risk for having symptoms as well as worse quality of life. And so when we're interviewing them, we really need to make sure we're asking them all the right questions about how their atrial fibrillation is impacting their day-to-day activities and their life.
So to summarize for our listening audience, this is the first important results at 1 year from the largest existing registry on atrial fibrillation in more than 10,000 patients. And comparing men versus women, women are sicker at baseline in terms of their characteristics. Treatment pretty similar between men and women. Outcomes, surprisingly, better in the women than in men with respect to hard endpoints. But symptoms, both at baseline and at 1 year, worse in women as measured objectively with a quality of life survey, and still worse at a year, suggesting that the treatment didn't adequately address their symptoms. Does that basically summarize it for the audience?
Absolutely. So even though women have better survival with atrial fibrillation, they still may not feel well, and that's an important thing that we need to focus on when we're taking care of.
Well, Jonathan, thanks for sharing this message with the ACCEL audience. I think it's something they can apply almost immediately in their clinical practice after they hear this interview. Thanks for coming.
Thanks so much for having me.